Hello viewers, good day to all of you. This is Dr. BK for you, and today I am going to be discussing about a very interesting topic, that is the hip joint. Now, our learning objectives for the hip joint will be, so as any other joint, we would be first understanding the type of the joint, followed by the articulating surfaces, the bones taking part in the joint, then the ligaments. So that is the various ligaments which are rendering support to the joint, followed by the other supports apart from the ligaments, that is muscular or any other extra ligamental factors which come into act to render support to the joint. Then the relations of the joint, so that is what are the structures which are present in and around the joint, followed by the blood supply and the innervation of the joint. Then the movements, various movements which is possible in the joint, and the muscles which are producing these movements. And finally, we are going to discuss about the applied aspects of the joint. Now, it is a synovial joint of ball and socket variety. Okay, so like your shoulder joint is also a ball and socket variety. In the same way, the hip joint is also a very good example of the ball and socket variety of joint. Okay, but when you compare it with the shoulder joint, it is actually a more stable joint. Okay, so we are going to see why it is stable and how it is stable. Then it is a multi-axial joint, which means it permits movement in more than one axis. Okay, so basically you have a transverse axis, you have a vertical axis, and then you have an antero-posterior axis. Hip joint permits movements in all these axes. It is a multi-axial. Okay, so it is actually, because of its stability, doesn't mean that it compromises on the mobility of the joint. It is also a very much mobile joint as compared to the other joints in our body, but only thing is slightly secondary to the shoulder joint. Okay, so there great degree of mobility where you can achieve the shoulder joint even up to 360 degrees mobility you can achieve, but here that way it is not possible. But anyway, it is very much a mobile joint which has got very great range of movements. Now coming to the articulating surfaces, so as it is a ball and socket, the ball of the joint is represented by the head of the femur, which is 2/3 of a sphere. Okay, sphere. The head of the femur is the ball which represents almost 2/3 of a sphere with some flattening on the upper surface. And in the center of the head, you see a depression which is actually called as the fovea or pit. Okay, so that is actually gives attachment to a ligament, that is the ligament of head of femur or round ligament of femur. The whole of the head is actually covered by the articular cartilage. The articular cartilage also extends to an area in the neck, and the cartilage is thick at the center and thin at the periphery. Okay. The neck of the femur is actually directed forwards, upwards, and medially. Okay, so it is actually directed forwards, upwards, and medially. And one important aspect which you have to note is the neck shaft angle, which is at an average of 125 degrees in case of the adults. Okay, not only that, in adults there is also a forward tilt of the head and neck, forward tilting of the head and neck up to 15 degrees. In children, this neck shaft angle is about 160 degrees, 160 degrees. So it is a more of an obtuse angle, increase, the angle is increased. Okay, and the forward tilt is also more, the head and neck, the forward tilt is again more than 30 degrees. Okay, now apart from that, the neck shaft angle is very, very important for the movement, mobility. If the neck shaft angle is not present, then naturally what happens is the femur would have been somewhat immobile. Your hip joint will not have this great degree of mobility. It is mainly by the neck shaft angle, and not only because of that, the neck is comparatively long and narrow as compared to the head of the femur. So these two things, what happens is, gives an extra mobility to the joint in spite of being a stable joint. So that is about the ball. Now we are going to see the next articulating surface, the medial or the proximal. The ball forms the distal or lateral articulating surface. The socket is the medial articulating surface which is formed by the acetabulum. So you are able to see this cup shaped socket which is actually called as the acetabulum. The acetabulum, if you look inferiorly, it is not complete. It shows a notch which is actually called as the acetabular notch. The articulating surface of the acetabulum is called as the lunate surface, which is smooth, and again it is lined by the articulating cartilage or articular cartilage. The notch or the gap is bridged by a ligament which is the transverse acetabular ligament, and that is also lined by the articular cartilage. So that also forms an articulating surface. If you look at the acetabulum, it is actually a union of a Y-shaped cartilage. So it is contribution from the ilium, pubis and the ischium. So it starts ossification centers, secondary centers appear by around 16 years, and the ossification is completed by 20 years of age. For the acetabulum to get fully ossified, it gets 20 years. So I told you transverse acetabular ligament bridges the gap, and along the margins of the acetabulum, what is attached is the acetabular labrum. Okay, so it is actually called as the acetabular labrum, which is a fibrocartilaginous rim, same like your glenoid labrum of the shoulder joint. It is called as the acetabular labrum, made up of fibrocartilage. Okay, the transverse acetabular ligament can be considered something like your labrum, but it has got only the fibers and it does not have the chondrocytes. So that is why you cannot call it as a cartilage. Okay, so the acetabular labrum mainly increases again the depth of the socket. So since it gives an additional covering, so the socket becomes a little more deep, and thereby the joint is all the more stable. So what happens is, the chances of dislocation of the hip joint reduces. So this adds to the stability of the joint. Then if you look into the depth of the acetabulum, it is only filled by the acetabular pad of fat. Okay, the acetabular pad of fat, and fat means it is not lobulated or thick fat. Here the fat is present in the form of liquid in the living state. In the living state, what happens is, the fat is actually present in the liquid state, and it is also called as the Haversian fat. It is actually called as the Haversian fat. So the fat, what happens, and it is lined by synovial membrane. So that means it is not inside the joint cavity. It is external to the joint cavity. But what happens is during various movements of the head of the femur, the fat slides out and fills the gap. So that is why it is more not of a more solid form. It is in the form of a Haversian fat. Okay. So acetabular labrum increases the depth, and mainly the lunate surface is the articulating surface. Now, if you look, the posterior superior part of the acetabulum is actually very thick and forms a shelf-like bony buttress. Okay, and forms a shelf-like thick bony buttress. The posterior superior part of the acetabulum. Okay, because that part is where most strain is taking place during your extension. So when you are standing in extension, what happens is the head is mostly impinging on the posterior superior aspect of the acetabulum. So that part of the acetabulum is very thick, form a thick bony buttress. The internal structure of the acetabulum you see. So naturally lot of lamellae will be there. Lamellated bone will be there. Okay. So as I told you, the lunate surface along with the transverse acetabular ligament is actually lined by the articular cartilage. So now we have seen about the articulating surface. Now the ligaments of the joint. So one is the fibrous capsule, followed by the round ligament of head of femur, are called as ligamentum teres femoris. Then you have iliofemoral ligament or ligamentum bigilu. Then you have ischiofemoral ligament, pubofemoral ligament, and transverse ligament of acetabulum. Okay. So capsule, iliofemoral, ischiofemoral, pubofemoral. Then you have ligamentum teres femoris, and then you have transverse ligament of acetabulum. So these are the ligaments. We will see these ligaments one by one. So first, what you see is the capsule. Capsule encloses the articular surfaces or articulating surfaces, and it is attached to the margins of the articular surface. So that means it is attaching to the margins of acetabulum, and anteriorly it merges with the acetabular labrum. Okay, that is superiorly or proximally. Distally, if you come, the capsule not only to the head but also extends along the neck of the femur and attaches to the intertrochanteric line and also to the base of the greater trochanter and also to the lesser trochanter. Okay. So that is the proximal attachments and the distal attachments. So proximally it attaches to the acetabulum beyond the labrum, and anteriorly it merges with the labrum. Distally along the intertrochanteric line you see it is attached also to the base of the greater trochanter and also to the lesser trochanter. Up to here intertrochanteric line it extends. And you see the fibers of the capsule, they are somewhat spirally arranged or twisted. Posteriorly when you look, the fibers distally on the posterior surface, they don't reach up till the intertrochanteric area. They don't reach up to the intertrochanteric area. But instead what happens is they fall short just 1 centimeter prior to the intertrochanteric crest. Until there they stop there. Okay. They are spirally arranged. So that means the capsule becomes very taut. That means tight during your extension. Complete extension, and the capsular fibers are relaxed during flexion. Okay. So this spiral arrangement again what happens is locks the hip joint. Then Some of the fibers, what happens is from the neck, especially from the anterior part of the neck, some of the fibers, they course back towards the head. From the neck they pass backwards towards the neck as the retinacular fibers. Okay, so from the distally, from the neck anteriorly especially, they run towards the head of the femur and they are called as the retinacular fibers. So these fibers, mainly what happens is they protect the blood vessels which are traveling from the neck to the head of the femur. Okay, mainly for the protection of the blood vessels. Deeper fibers, if you see the deeper fibers, they form a tight collar like band, and that is actually called as zona orbicularis. That is actually called as the zona orbicularis. So the deeper fibers of the capsule, which are like a tight collar like band and circular, they are called as zona orbicularis. The ischiofemoral ligament actually fuses with the zona orbicularis fibers. Then between this tight attachment of the capsule and the neck of the femur, the synovial membrane might protrude, forming a bursa like for the tendon of obturator externus. Okay, for the tendon of obturator externus, there may be a protrusion of the synovial membrane. Okay, so I already told you that the fibers are spirally arranged and they are very tight during flexion and relaxed, tight during extension and relaxed during flexion. The infiromedial part of the capsule is most weak. It is not reinforced by any ligaments, like same like your shoulder joint, where we have seen that inferiorly it is not supported by any structures. Your rotator cuff supports the joint anteriorly, superiorly and posteriorly, but not inferiorly. Only the capsule just dips 1 centimeter, but here also, but it is not as weak as the shoulder joint. Okay. Next, what happens is, coming to the capsule of the shoulder joint, again one more thing what I would like to add is, the capsule is very thick and it invests the joint. Second thing is, if there is going to be a dislocation due to the tear in the capsule, it also does not undergo dislocation very easily, because half of the sphere is actually present inside the cup and the acetabular labrum and the capsule, they merge and fuse. So because of that, what happens is, the head is held in its position even though the capsule is damaged inferiorly. Inferior part of the capsule is damaged. Okay, but the weakest point of the capsule is the infiromedial part. So that is why what happens is, in sudden hyperabduction, so sudden forced or hyperabduction, then the capsule might tear and there is a chance of the head of the femur dislocating inferiorly. Coming to the synovial membrane of the hip joint, so it lines the interior of the capsule. Okay, so this green color one, what you are able to see is the synovial membrane, which is cut open for you to see the joint cavity. So it lines the interior of the capsule and it also lines your acetabular labrum. Okay, the interior of the labrum, and also the neck of the femur is lined by the synovial membrane. The synovial membrane lines the interior of the capsule and also the acetabular labrum. Then if you look at the synovial membrane, what happens is, it also invests this intracapsular structure, that is the ligament of head of femur, like a flattened cone. Then if you trace it more medially, the base of the cone somewhat it expands and diverges to get attached to the capsule. Below and above it lines the acetabular fat. So fat is outside the synovial membrane. Okay, So actually what happens is the synovial membrane lines the acetabular fat. So fat is extra synovial. It doesn't come into the joint cavity. So that is the lining of the synovial membrane along the round ligament of femur, ligamentum teres femur. Okay. Protrusion of the capsule again takes place between iliofemoral and ischiofemoral. That is again no ligament is reinforcing the capsule there. And also between the capsule and femur there is a extension of bursa for the obturator externus tendon, which I have already told you. Transverse acetabular ligament, you are able to see here, that is actually the transverse acetabular ligament, which is actually bridging your acetabular notch. It represents something like a labrum without the cartilage cells or chondrocytes. Blends with the base of the ligament of head of femur. So this ligament of head of femur, it somewhat expands or diverges and gets attached to the acetabular ligament. Between this acetabular ligament and the capsule, the blood vessels that traverse to supply, they are the acetabular branches of the obturator artery and also acetabular branches from the medial circumflex femoral artery. Ligament of head of femur, it is actually called as ligamentum teres femoris. Triangular in shape, apex attached to the fovea or pit, seen in the center of the head of the femur. Enclosed by a synovial membrane, and synovial membrane is going to get attached here to the margins of the transverse acetabular ligament. It is going to blend with the transverse acetabular ligament. Base is attached to the acetabular notch. Synovial membrane as well as the base of this ligament is attached and blends with the transverse acetabular ligament. Now as such, this ligament of head of femur does not render any support to the hip joint. If at all, what happens is it is actually transmitting the blood vessels to the head of femur, especially in children and infants. Okay, because the fusion is not taking place, still there is epiphyseal cartilage is present, it has not fused. So that is why what happens is there is not going to be a connection between the epiphyseal and the diaphyseal arteries. So what happens is vascular necrosis takes place if there is a fracture. The head of the femur or the neck of the femur will not receive any blood supply. It might go for avascular necrosis, most commonly in the children. So the ligament as such does not render any support, only it transmits the blood vessels. The next very important ligament is the iliofemoral ligament. It is also called as ligamentum bigelow. Inverted Y-shaped, strongest ligament in our body. The stem of the Y is attached to the anterior inferior iliac spine. Then it has got a medial and a lateral bands. The lateral band is actually attached to the upper part of intertrochanteric line. And here the lateral band is attached to the lower part of the intertrochanteric line. So from the stem, the two arms of the Y, they diverge and getting attached to the upper and lower part of the intertrochanteric line. So the intermediate area is the place where the capsule is weak. Not only that, between the iliofemoral ligament and pubiofemoral ligament, sometimes you see a bursa. It might be a protrusion of the synovial membrane also. So that bursa is for the tendon of psoas major, or you can call it as iliopsoas tendon. So iliopsoas tendon is going to coming and getting attached to the lesser trochanter. So thereby what happens is, to avoid any friction, so there is a bursa which is present for the tendon of iliopsoas. Okay. So when you are standing, what happens is the whole weight of the pelvis and above the trunk of your body is held by this iliofemoral ligament. So that is why it is actually called as the strongest ligament. Now the center of gravity, the axis for the center of gravity passes behind the head of the femur. So naturally there is a tendency for us to tilt backwards. We tend to fall backwards. So when we tend to fall backwards, that is prevented again by the pull of the iliofemoral ligament. Okay, because of the gravity we tend to fall backwards, and that is counteracted by this iliofemoral ligament. So now you can understand why actually it is a very strong ligament. Prevents the backward tilting of the pelvis, and tension of this ligament tensed. When the ligament tensed, it also prevents hyperextension. You are in extended position, a vertical line. Beyond that, hyperextension is limited. Very minimal extent hyperextension is possible. Beyond that, it is limited by when the ligament becomes tensed, it won't allow further hyperextension. The next ligament is the pubofemoral ligament. Covers the infromedial part of the capsule. It covers the infromedial part of the capsule and attached to the close to the acetabular margin near the iliopubic eminence. Near the iliopubic eminence, blends with the capsule deep to the medial band of the iliofemoral ligament. Next, posteriorly, what you see is the ischiofemoral ligament. So attached to the posterior part of the acetabulum. Fibers go spirally and get attached to the zona orbicularis part of the capsule. So that is the deeper part of the capsule, it gets attached. So we have seen about the iliofemoral ligament, we have seen about the ischiofemoral ligament, then we have seen about the pubofemoral ligament. Iliofemoral ligament, anteriorly it strengthens the capsule and it is the strongest ligament, prevents the backward tilting of the pelvis. Pubofemoral ligament strengthens the capsule medially, not completely medially, inferiorly, okay, but not completely inferiorly. Ischiofemoral ligament strengthens the capsule posteriorly and blends with the zona orbicularis, that is the deep fibers of the capsule. Now coming to the relations, so a cross section, more than a cross section, it is actually a longitudinal or sagittal section, parasagittal, not mid-sagittal, passing through the hip joint. So that should be your hip joint. Mainly you are able to see the acetabulum attachment of the ligament of femoral head, acetabular fat you are able to see. Okay. Anterior relations is mainly the structures forming the floor of the femoral triangle. Very easy to remember. So iliopsoas tendon or iliacus or psoas major, pectineus, and in front of it what you see in between the iliopsoas, iliacus and psoas, you have the femoral nerve. Okay. So you have pectineus, iliopsoas, iliacus, and then straight head of rectus femoris. So that's why I told you very simply, structures forming the floor of the femoral triangle forms the anterior relation of the hip joint. Posterior relation, mainly main muscle what you see here is the piriformis muscle, tendon of piriformis. Structures below that, emerging below the piriformis. So gemellae, superior, inferior, obturator, internus, sciatic nerve, all those things, and quadratus femoris. Okay. So superior, inferior gemellae, tendon of obturator, internus, quadratus femoris, all forms the posterior relation. Superiorly above, mainly by the gluteus medius and minimus to some extent, and reflected head of rectus femoris above. Inferiorly, it is actually the adductor part of the pectineus muscle and the obturator externus tendon forms the inferior relation of the hip joint. Okay. So inferiorly it is the medial or adductor part of the pectineus and obturator externus. Both are present in the adductor compartment. So here you are able to see, not exactly passing through the hip joint, somewhat below that, because here you are able to see the head in the socket, acetabulum, capsule, greater trochanter, all those things you are able to see. So that should be your massive gluteus maximus muscle. So in the front, the vasti muscles, rectus femoris and vasti muscles, and here iliotibial tract with the tensor fascia lata, you will be able to see here, that should be your gluteal minimus or medius muscles. So I just want to include this picture so that you have an idea about how these structures are disposed around the hip joint, or for that matter in the thigh itself, the compartment, the extensor compartment, the gluteal muscles. Coming to the nerve supply of the joint, mainly it is supplied by branch from femoral nerve, that is through the nerve to rectus femoris, anterior division of obturator nerve, then superior gluteal nerve will give a branch, nerve to quadratus femoris will give an articular branch. Okay. So Hilton's law, a nerve supplying the joint will also supplies the muscle and the skin around the joint. So based on that, femoral nerve, obturator nerve, nerve to quadratus femoris and the superior gluteal nerve. Sometimes occasionally even your sciatic nerve, if at all present, sometimes occasionally might give a branch. Sciatic nerve, not always, but it might give an articular branch to the hip joint, and sometimes accessory obturator, if present, also gives a twig, articular twig to the hip joint. So blood supply mainly by the medial circumflex superior gluteal arteries, lateral circumflex arteries, obturator artery. Okay. Mainly to the head of the femur, because it is present within the capsule. You have medial epiphyseal arteries, which are acetabular branches of the obturator artery. Then lateral epiphyseal arteries are branches from the medial circumflex arteries. So medial epiphyseal and lateral epiphyseal arteries. Medial circumflex. Then you also have lower metaphyseal part supplied by medial circumflex. Lateral epiphyseal arteries are more predominant, and they supply through the neck and also the head of the femur. So necrosis of the femoral head takes place if mainly the lateral epiphyseal arteries are torn during the fracture of the hip. Okay. So these are the arterial supply or the blood supply to the hip joint. Okay. Now just we will see in brief about the supports of the joint. So mainly the stability of the joint by the architecture of the bones. So based on the design of the bones itself are designed to provide support to the joint. So main thing, you all know that very deep acetabular cup, not like the shallow glenoid fossa, because here more than the mobility, stability has to be taken care because of the weight bearing, and the center of gravity is actually acting on these joints. So that is why comparatively fewer subluxations or dislocation. Okay, a subluxation is nothing but a partial dislocation, not a complete dislocation. Hip joints subluxation and dislocation are not common, especially in a very younger people. Then the muscles add again strength to the joint which is present around the joints. They are all very massive, very large muscles, gluteus maximus, adductor magnus, all these muscles. What happens is the tone of the muscles and the size of the muscles are all supporting the joint, and strongest ligament supports the joint anteriorly, that is the iliofemoral ligament, prevents the tilting of the pelvis backwards. In spite of that, there is mobility because all movements of the hip are actually associated with the pelvic rotary movements also. The pelvic either rotates medially or laterally during your movements of the hip, especially when you are walking. There is striding of the pelvis. Then the neck shaft angle and a narrow neck than the head all adds to the greater mobility of the joint. So here it is a well balanced joint both for stability as well as the mobility. So now we come to the movements. First is flexion and extension, which takes place around a transverse axis passing through the femoral head. Okay. So it actually passes through the femoral head, the axis of movement for the flexion and extension. In an extended knee, the flexion is around 90 to 100 degrees. But when the knee is flexed, then what happens? Up to 120 degrees, you can flex your knee. Up to 120 degrees, you can flex your knee. Not only that, complete flexion is when your thigh is approximating your trunk. For this, not only the flexion of thigh, but also your trunk flexes or bends forward to some extent. Okay. Then, limiting of the flexion, especially when the knee is extended, is due to the tension of these antagonistic muscles, hamstring muscles. They are responsible for the extension of the knee. Okay. So, tension, when these muscles are stretched too much, when you flex it, naturally they limit the flexion. Then, extension is when your trunk and your hip or your lower limb is in a straight line. That is actually called as the extension. During an extension, all the ligaments are tight and your joint maximum congruency is there. Surface contact between your ball and the socket. And because of this, the joint is in a screw home movement, in very safe. There is no, you cannot tell nil, but there is very minimal chance for the dislocation during extension when you are standing. Hyperextension, to some extent 10 to 15 degrees of hyperextension is actually possible, but beyond that what happens is the tension of your iliofemoral ligament prevents hyperextension beyond that. So a minimal hyperextension of 10 to 15 degrees is possible. So mainly the muscles which bring about the flexion, chief flexor is your iliopsoas tendon. So that is the prime or the chief flexor of the hip joint, assisted by your pectineus, rectus femoris, sartorius, and to some extent gluteus maximus and hamstrings. Your gluteus maximus is an extensor of the hip joint. Your hamstring is again extension. So this is for flexion, gluteus maximus and hamstring. Now again, when does gluteus maximus come for extension is when you want to extend against the gravity, that is getting up from a chair, from sitting position you want to stand, extending your hip, then the gluteus maximus come into action. Otherwise, normal extension during standing, it is the hamstrings which actually take part, whereas gluteus maximus is comparatively inactive. The next movement what you see is the adduction. Adduction is when the thigh is adducted and it approximates with the opposite lower limb or the thigh, so that limits your adduction. And the axis for adduction and abduction takes place around an antero-posterior axis, again which is passing through the center of the head, antero-posterior axis from behind forward, and around the axis the adduction and abduction will take place. So not only by this one, tension of the lateral part of iliofemoral ligament. So when you keep adducting more than that, the iliofemoral ligament, the lateral part is attached to along the upper part of the intertrochanteric line, what happens is it gets stretched and that limits the adduction. Further adduction you can do it if the knee is flexed. Okay. So the range of adduction is increased when the knee is flexed. Then abduction. So abduction is more pronounced when you walk or when you lift your foot off the ground. Naturally, the opposite foot is off the ground. The unsupported pelvis of this side, which is off the ground, will be supported by the gluteus medius and minimus muscles, where abduction is more pronounced. In cases of persons with coxa vara, where the neck shaft angle is diminished, then what happens is the abduction is also limited. Why actually the abduction is limited in coxa vara is because what happens is the greater trochanter will very early go and impinge on the ilium. So thereby it will arrest further abduction in coxa vara, diminished or decreased neck shaft angle. So main muscles which bring about your adduction, adductors, adductor longus, gracilis, pectineus, all those things, and ischial part of adductor magnus. Abduction is mainly by gluteus medius and minimus. The prime abductors are gluteus medius and minimus, assisted by tensor fascia lata and sartorius. Okay. The next movement which we are going to see is the medial rotation and the lateral rotation, which takes place around a vertical axis. So transverse axis for the flexion extension, antero-posterior axis for the abduction adduction, and vertical axis around which it is going to take place for the medial rotation and lateral rotation. The upper end passes through the head of the femur, but the lower end actually passes through the lateral condyle when the foot is on the ground. When the foot is actually off the ground, then it might pass anywhere along the foot. It keeps on migrating the axis when the foot is off the ground, the axis for the internal or the external rotation. So for example, when you do internal rotation, what happens is the medial condyle goes posteriorly and the greater trochanter is brought forwards. Okay. So main structure which brings about the medial rotation is the gluteus medius and minimus. Now abductors are lateral rotators. Usually it is believed that abductors are lateral rotators by rule, but recent electromyographic studies, they told that adductors are actually bringing about the medial rotation. Adductors bring about the medial rotation. Okay. The main muscle which brings about the medial rotation is your gluteus medius and minimus. Psoas major is a medial rotator when the foot is on the ground, because the axis, because the muscle is actually inserted lateral to this axis of rotation. But when the foot is off the ground, it acts as a lateral rotator. So lateral rotation mainly by gluteus maximus. Again, it's a very powerful lateral rotator and assisted by these short muscles, piriformis, tricipital tendon, quadratus femoris. They are called as the short lateral rotators of the thigh. So we have finished about the muscles, movements, and the muscles producing these movements. Coming to the applied anatomy. So coxa vara, decreased neck shaft angle. So when there is a decreased neck shaft angle, what happens is abduction is limited, because the The greater trochanter easily comes and approximates with the ilium. Because of this, abduction is not possible. When abduction cannot happen effectively, there will be a drooping of pelvis. The next is coxa valga, whereas there is an increase in the neck shaft angle. When there is an increase in the neck shaft angle, what happens is adduction will be limited. Okay. So what happens is the adduction will be limited in case of coxa valga, where it is more than 150 degrees, the neck shaft angle. Congenital dislocation is more common in female children. Why? Because the lateral wall of the pelvis is vertical, and what happens is the posterior superior part of the acetabulum, I told you it's a very thick shelf like bony buttress, that is not developed properly. The acetabulum, the posterior superior part, is very poorly developed. Because of that, there is a posterior dislocation of the femur, that is called as congenital dislocation. And in that case, what happens, in the dislocated part, the capsule or the labrum sometimes might be inturned or outturned, which has to be surgically corrected. That is about the congenital dislocation. It is due to the non-development of the posterior superior part of the acetabulum. So thereby what happens is there is a dislocation of the femur posteriorly. Traumatic dislocation, apart from the congenital dislocation, traumatic dislocation, not very common. In traumatic dislocation, what happens is very rare and occurs in a flexed knee and adducted thigh. So when the knee is flexed and adducted, so a most common position is when you are driving in a road traffic accident. If it is flexed and adducted, then what happens is the tearing of the capsule takes place and head dislocates posteriorly. So you are able to see the posterior dislocation. Then apart from that, Perth's disease is avascular necrosis of femur head in children. I told you why avascular necrosis occurs most commonly in children is because any trauma to the hip region, if the blood supply is cut, then avascular necrosis of it takes place because the epiphyseal fusion has not taken place. So the epiphyseal arteries and the diaphyseal arteries, they would have not have been connected. Since there is no other source of blood supply, what happens is avascular necrosis takes place. This is called as Perth's disease. There is also something called as Perth's test, that is different to test the veins, especially the deep veins. So any pathology of the hip, the pain might be referred to the knee, that is because of the obturator nerve which supplies both the joints. Then fractures of the neck of the femur mainly taking place along the intertrochanteric line. It might be due to stress fracture or impacted fracture. In elderly, mostly subcapital osteoporosis, and because of that what happens is fracture of the neck takes place. So if it is intracapsular, again avascular necrosis is common. Okay. So only thing, immobility is advised, and proper splinting should be applied, so that what happens is there is a fusion. Okay. But in elderly, more than the fracture of neck, dislocation of the hip is more devastating. Then inflammation mainly of the synovial membrane and all those things, arthritis of the hip, it's more can affect the hip like your knee joint. Then hip replacement, arthroplasty. Then apart from that, certain things to identify whether there is a fracture or not. Nellatone's line. If you draw a line from the anterior superior iliac spine to the ischial tuberosity, it should pass through the tip of greater trochanter. If the greater trochanter lies well above the line, or if the greater trochanter lies well below this line, the tip of the greater trochanter, then that indicates that there is a fracture in the neck, or most commonly the fracture of the neck. Now, in persons who are very obese and lot of fat, it is very difficult to identify the ischial tuberosity. So, in those persons, the importance of Nillenton's line cannot be taken into account. Then you have a Bryant's triangle. So, horizontal line from the anterior superior iliac spine, you draw a line. Then you draw a vertical line from the tip of the greater trochanter to the first. Then you connect this line, another line from the anterior superior iliac spine to the tip of the greater trochanter, that is actually called as the Bryant's triangle. Again, the contour of the triangle helps to give an idea whether there is a dislocation of the hip. Bryant's line is measuring the distance between this anterior superior iliac spine and the greater trochanter, which should be approximately 5 centimeters. Then you also have Shenton's line, and one more thing is Shoemaker's line. So, Shenton's line mostly seen in radiographs of the hip. You are able to see a curved line from the upper border of the obturator foramen and lower border of the neck of the femur. If you see a contour of the line, then naturally what happens is, this line is mainly helpful in determining the fracture of the neck of the femur. So, you don't get a curved line, then naturally what happens is there might be a fracture of neck of femur, but if you get a curved line, that doesn't mean that fracture of neck or femur has not taken place. So, you have to suspect, if you suspect a fracture of neck or femur, you cannot simply or completely rely on this Shenton's line. So, Shoemaker line is anterior superior iliac spine of both sides. When you extend it, it should pass immediately above the umbilicus, where these two lines should intersect. Okay. So, that is actually called as the Shoemaker's line. So, these are all some of the what happens is some tangents which is useful in determining any dislocation or fractures of the hip. So, thank you very much for your patient listening, and we will meet again in one more lecture.